It begins shambolically. Good. Right. So, health economics. I don't know if you're familiar with this. Then it has been referred to as the cheerful face of the dismal science. Okay. By Alan Williams in 1987 in his paper. And his reasoning for this was that economics is known as the dismal science, for those of you that don't know. And he said that, like, the economics is all about death and taxes, or there's some famous quotes about the only thing inevitable in life is death and taxes. And he said what's cheerful about health economics, even though it's obviously about death and taxes, is that it's about how can we prolong survival as much as possible for the lowest amount of taxes. So that's why health economics is cheerful, apparently. As part of the same article, he also introduced this plumbing diagram, as it's referred, to sort of overview what health economics contributes and how it all fits together. I'm not going to go through that in detail because I'm going to use a different system of thinking about the various components of health economics. But first of all, and this is probably a rehearsal of things that you know very well, just a discussion point about why do we think health and healthcare is any different to the role of economics in general? Any thoughts on that?
You can't, there's a whole thing about it's not like a price on health, like you purchase like healthcare, but you can't buy like health, which is
Okay.
a bit different than standard economic goods or services.
Yeah, so it's kind of like an outcome that results from things that you consume, maybe.
Mm-hmm.
Okay. Any other thoughts? No? Okay. Well, I think that relatedly, I suppose, Kenneth Arrow kind of founded the discipline of health economics with this article in 1963. So when people talk about where health economics began, they often refer to this seminal article by Ken Arrow. And he focused on the economics of medical care specifically. And he said that it's quite different because of various things, uncertainty, obviously, from the title, but also information asymmetry was a big feature of this article. So consumers of healthcare maybe they're not fully informed consumers in the way that they might be in a different market. That's the claim. So basically medical care, healthcare, is different in this way, and uncertainty refers to the fact that you just don't know when you're going to have a health shock, right? So it's something that just will happen to you, and therefore that's why most systems, health systems, have developed some way of coping with that through insurance mechanisms, be that either private insurance, social insurance, or government provided healthcare. They're all forms of essentially insurance that mean that you pay on a regular basis, but you don't pay huge amounts when you fall ill at any particular point in time. So that's what Ken Arrow kind of thought about when he thought, why might medical care be different? There's quite a lot of other reasons, I think, that health economics might be considered different. I think that's a good point that you made about health. Some people talk about there's being a derived demand for healthcare from the fact that you actually demand health. But also people have kind of talked about health being something that's a merit good. It's good in its own right. It's not just good for people in terms of the utility that they derive from it. So it's something that maybe should be the objective in itself as opposed to utility, which is what mainstream economics takes as the objective in most mainstream economics work. Okay, also, I mean, healthcare, thinking about that, if we think about, this is really Economics 101. For those of you that are familiar with health economics, apologies, but within mainstream economics, if you're taking it, say, at high school, what they'll tell you is that the standard model of perfect competition is one where there's many sellers and they take the price. They don't have an influence over what the price is. It's just determined by the market. There's many buyers, there's freedom of entry and exit to the market. The products produced are homogeneous, there's perfect knowledge and information, perfectly mobile factors of production, and no externalities. And there may be some other assumptions there. Now, within economics, economics is to a large extent a study of where these assumptions fail. So I'm not going to say that economics doesn't consider these, because it clearly does, and most of the work is focused on relaxing these various assumptions. Because if these assumptions hold, then the market solves everything and everything's hunky-dory. If it doesn't, then there needs to be some form of regulation. Now, in healthcare, this model is completely inappropriate. It's just not. I've put here the laughing and crying smiley because it's laughable that you would think that healthcare meets these assumptions, but it's also something to cry about because it means we've got a lot of hard work to do. Obviously, I've touched upon perfect knowledge and information, consumers of healthcare. I mean, unless you're sort of like incredibly well-educated doctor or something, you're not going to have perfect information about how healthcare is going to affect you in various ways. But on every single one of these, to be honest, it's unlikely that you could make an argument that healthcare is going to follow it, in most healthcare systems at least. So yeah, perfect competition isn't really going to get us very far within healthcare. It looks quite different actually in reality. So this is just a sort of sketch of, I guess, the UK system, but maybe it's more generalisable than that. So we've got patients, I guess the consumers of healthcare ultimately, and they've got different needs, different preferences. A lot of economics is concerned with analysis of preferences, and also how that ultimately affects behaviour. There's uncertainty, there's income constraints. There are lots of externalities within communicable diseases, for example. There's an externality that's quite obvious there. And there's also a large focus on equity and equality in terms of health inequalities and so on. That's the patient side of things, but then when it comes to the supply side, I suppose, it's really quite complicated in healthcare, and it doesn't follow a sort of simple model. Providers, here we've got sort of like an example of a provider is the pharmaceutical industry that's providing new pharmacological products. And then there's the payers, such as the NHS. They're actually buying those pharmacological products on behalf of patients. And because of the complicated nature of this, we also have regulators sitting in between all of this. So just to use that example of pharmaceuticals, we have groups like NICE in the UK, where they're sort of known as the government watchdog of new drugs in the UK. So basically a new drug that gets developed, the NHS is deciding whether they want to buy it or not. NICE sits in between as this sort of advisor to suggest whether the expensive new drug is worth it or not in terms of whether the drug's cost effective. And that involves a lot of analysis on how effective is it, which is in itself a very complicated question because there's going to be a primary outcome, but there's also adverse events and whatever. But then there's also the issue of whether the price is a fair price or not that's being charged. And this is just the UK, which is, to be honest, a relatively simple system because we basically have a single payer system. And the sort of private involvement in UK healthcare is pretty minimal, sometimes considered negligible and ignored in a lot of health economics analysis. So this is quite a simple case. It gets a lot more complicated with more plural, heterogeneous healthcare systems. And that's probably going to be the case in the countries that you're stationed as part of your fellowship. So, I'm now going to sort of begin my overview of health economics and start off by talking about methods quite briefly. Because often I haven't kind of like delved into the science of how to distinguish these things, but when talking about a discipline, sometimes it's like how do you approach a question is what's referred to, which is kind of like methods, and then the other thing is what kind of questions do you try and answer. Okay, so this is the how do you approach the question part of thing, and then actually the bulk of what I'm going to talk about is the kind of questions that health economics tries to answer. So on the methods front, I think it's a bit of everything really. So there's a lot of things within economics that are potentially useful within health and healthcare. economics is sometimes referred to as the science of scarcity. It's about how do we make the best use of the limited resources that we have. And to answer those questions, a whole range of methods have been used. In health economics, the same applies. It's just applied to health, basically. So there's a lot of things involved in that. First of all, I mean, some of these maybe you wouldn't necessarily consider a method necessarily, typically, but like normative reasoning. So there's this distinction in economics between positive and normative, and it's also referred to a lot in health economics. Positive questions are just things that are quite dry and objective questions that you can try and answer with analysis. A normative question is something that it's more like should something be done, so there's some value judgment going on. So one example within health economics is when talking about disparities in health outcomes. So there's quite a large focus on health inequalities within health economics. But people have said, well, should we really be concerned about health inequalities? That's an equality of outcome. Is that what we really want to achieve? Or are we more interested in things related to equality of opportunity? So we're more interested in, like, is there the capability of everyone to achieve the same level of health? Now, choosing between those two perspectives on this is a normative question. There's no way that someone can take their calculator and give you the answer to that. It more requires normative reasoning, drawing on maybe literatures in moral philosophy or whatever it might be. And there's a large chunk of health economics that is exactly that, and same with economics really, but certainly within health economics. Microeconomics is used within health economics. So microeconomics, looking at individuals, as in patients, but also providers and specific markets. This is probably the bulk of what is done within health economics. That's why here in my next bullet point, macroeconomics is actually a question mark. I think within health economics, obviously macroeconomic questions are relevant, but generally speaking, macroeconomics methods are not generally used, I guess. They're not hugely common. They exist, but they're not, if you look at published papers, they're more often microeconomics in focus, or the methods that are used. Econometrics is hugely important. As much as anything, within health economics, we're often interested in predicting how something will change if something else changes, holding everything else constant. And to answer that kind of question, we can use the econometrics toolkit. Essentially, it's statistics applied to economic questions, or it's statistics where the method that you use, the approach that you use, is informed by some economic model that helps you come up with a statistical model. In health economics, and this is probably quite different to economics in mainstream economics, we also use epidemiology, and that's just because that's the nature of health. We need to use insights from epidemiology, and so you see papers in health economics journals that use epidemiological methods, or that are generally considered the domain of epidemiology, but of course are completely relevant for health economics. And then finally, qualitative methods are used within health economics. Very often it's important to kind of understand the mechanisms of action for various things that are going on. So economists sometimes are quite happy to have somewhat of a black box in terms of how input goes to outcome or output, but it can be quite useful to actually delve into that black box using, say, qualitative methods. Perhaps it's a little bit, again, not justifying of a question mark, but perhaps there's not quite as much qualitative work done, particularly in Che. We tend to be quite quantitative in our focus, but that's not to say that qualitative work isn't equally important, because of course it is, for those reasons that I've gone through. Okay, that's a whistle-stop tour of methods. There's probably absolutely loads that I've missed off. Any questions or anything at this point? Okay. So I'm now going to address the questions that tackle within health economics. And to do this, I've drawn on a study that looked at 4 decades of health economics through a bibliometric lens. So because it's bibliometric, what this basically means is it was drawing on the sort of canon, if you like, of published work in potentially could be considered health economics by Collier and Wagstaff, and the references on the slide here. And they organised their study by placing each paper into a specific topic, and they had 12 topics in total. So we've got health and its value, efficiency and equity, determinants of health and ill health, public health, health and the economy, health statistics and econometrics, demand for health and healthcare, medical insurance, supply of health services, human resources, marketing healthcare, and economic evaluation. So it's kind of like a little bit different actually to some of the lists of topics you've already had today in terms of what Che do and what Tansey does. Some overlap, but also some differences, and I think probably quite a big issue here is that probably this drawing on the published work probably neglects a little bit global health issues, and I think that's an important discussion point for later on. Obviously there isn't here a global health topic, which is perhaps quite surprising. Perhaps it reflects that it's only recently that, more recently, the issues around global health have started to be tackled by health economists. Massive generalisation, but perhaps that's why that's going on here. Or perhaps maybe you could say, well, global health is actually just talking about these topics, but just in maybe low and middle income countries. That's how some people define global health and its outlook. But yeah, perhaps there are some things that we're doing within Tansey that don't necessarily fit within this for that reason, because we found that that's what's actually demanded in terms of what people want to know. So I'm going to go through each of these topics in turn. So, health and its value. So in this one, I've decided to pick on an issue that I feel is particularly relevant for global health, and that's, what is health? Right, this is a huge question, and if I'm being perfectly honest, just my personal opinion, I don't think we have a perfect measure of health. It's going to be very difficult. Like, health is entirely multidimensional, personal, everything, it's difficult. So when we try and measure health, it is reducing it down to something that's pragmatic, I guess. And what's typically done within health economics, but this isn't the only way of doing it, is to measure health using some generic measure that combines information on morbidity or health-related quality of life and survival or life years. And that's done in 2 main ways, either through using QALYs, which is what we use in the UK, quality adjusted life years. Sorry if you're totally familiar with this, by the way. And you may hear people in the talks throughout the day talk about QALYs, but you may be more familiar with DALYs, which are more typically used in the global health context. As this diagram points out, there's a relationship between the two. QALYs is basically like good health. You want to have more QALYs. DALYs is bad. It's bad health. You want to have fewer DALYs. This is a little bit of a simplification because how they're derived actually differs slightly, but in principle that's quite a good way of thinking about it. Health and its value. So we're talking earlier about, does health have a price? Well, there's actually a whole literature that tries to derive how valuable health is to individuals. And I've just cited one paper here that basically looks across studies that have used methods like willingness to pay surveys and value of statistical life to try and arrive at the value of a QALY or a DALY. And you'll see that there's quite frequently mentioned estimates that basically these valuations fit within roughly 1 to 3 times the GDP per capita within a particular country. And crucially, that these might be used as a threshold for determining whether something provides good value for money or not. This is hugely disputed, and we've done a lot of work in Che that kind of tries to come up with a different approach to working out what kind of drugs are affordable or not. I think I refer to that in a little bit, but if not, we can discuss that later on if that's something that's of particular interest.
Sorry,
Did you
Yeah.
say what those stand for?
Which one, sorry?
Quality.
Yeah, I don't think I did. Sorry about that. I sometimes get sucked into the acronym soup, which is also, this is an introduction to health economics, so health economists use a lot of crappy acronyms. So QALY is quality adjusted life years, and DALY is disability adjusted life years. So this is why, as I say, like QALYs are good because you want to have better quality. DALYs are bad because you want to have less disability if possible. Okay. Is there another question or anything? Okay. Please just stop me if I've used acronyms too much at any point. Okay. Next up is efficiency and equity. You know, obviously, with any of these topics, you could spend a whole day talking about it. Here are just some key studies, I guess, that have been published that might be of interest. This one on the left here is Fleurbain and Schockhart, where they talk about equity in health and healthcare, and it's about how to sort of think about it, but there's also a load of work about how to measure equity. So how can you come up with some sort of like index, let's say, of whether it's equitably delivered or not in healthcare. And there's various different concepts that underlie this that you can look into if you're more interested. So here is a good example of a study that actually tries to quantitatively take on indexes of equity in healthcare. And that's by Wagstaff and Van Doorslayer. On the efficiency side of things, we're involved in, not me personally, but at CHE we do these annual measures for the UK NHS productivity, where we try and basically work out what sort of scale of outputs are achieved for the inputs that go into the NHS, and how has that changed over time. So health economists are involved in these quantitative and also quite normative questions when it comes to efficiency and equity. I'm going to have to hurry up a little bit to get through all these. Okay, determinants of health and ill health. So obviously this is going to be a big question for health economists. What actually determines whether people are healthy or not, or whether countries are healthy or not? There's a whole range of things that I could have chosen to talk about here, but one quite interesting theory to think about is, okay, well in health we're interested in specific topics that might not lend themselves very well to economic analysis, where the workhorse of mainstream economics has always been the rational, fully informed consumer. Obviously, like I said, a lot of work in economics tries to move away from that very strong assumption. But in health economics, we might think about addiction, right? So how can that be rational? Addiction, you know, it doesn't lend itself very well to economic analysis necessarily. But economists have tried to tackle this by coming up with models that essentially are quite good at predicting the behaviour of addicts. And there's this theory called rational addiction. One of the big components of rational addiction is basically that the more you consume of something, the more you enjoy it. And this is a bit of a fun paper, I guess, on the right-hand side that says, actually, if you look at the way that people consume milk, that follows a rational addiction process. So, you know, it's kind of like, it's been a bit critical here, but rational addiction has been useful for predicting behaviours of addicts, which is hugely important within health, obviously. But also the same models you may find working for things that you wouldn't necessarily expect given the title of the model. Public health, you know, obviously a huge topic within health economics. And I looked through the bibliometric analysis of Cully and Wagstaff, one of the most highly cited papers that they've considered to be public health. And I saw this one that I remembered studying a while back that I thought was really interesting, about the 100 million missing women. And this is basically census. People often think that men and women, it's like 50-50, or maybe more women than men. But actually, that is the case in Europe and North America, but globally that isn't the case, right? So basically, the number of men outnumber women around the world. And so he kind of like has a paper that he talks about, well, what might be causing this, you know, this, and it's a very, very interesting and important paper. Work that we've done in Che, I've kind of plugged Che's work quite a lot throughout this, but, you know, public health questions that health economists might tackle might involve, for example, the use of taxes to reduce the consumption of bads or demerit goods, such as sugar. So we've been involved here in Che in analysing the impact of a sugar tax in Chile. And you know, they've found sort of like mixed results. It's the usual thing in economics that you get some consequences that you expect and some consequences that you don't expect. So this is why they've gone for this bittersweet success little headline there, which is very clever. Health and the economy. Okay, so I focused here on the economy and health, really, I suppose. But you may have come across this in the news. It was quite a big study. Basically, this is focused on the UK, where essentially this study here on the left in the BMJ Open tried to analyse how many deaths do they think are caused by austerity in the UK. Of course, health economists have delved quite a lot deeper than this paper does in terms of thinking about the mechanisms behind that. And this paper here by someone who's based at Che says that basically austerity does kill, but there's actually this effect on physical health, that recessions can be good for physical health. Maybe this is a sort of like high income country thing, but basically, essentially the argument, I guess, is reducing it quite a lot, is that you have less money to consume bad things during a recession. However, what this paper finds is, yes, there is this effect on physical health through recession, and obviously recessions and austerity have gone together, which makes it difficult to disentangle. But if you look at, say, mental health, what they found in this paper is that basically austerity is bad for mental health and also a recession is bad for mental health. So you get that double effect. Anyway, I'm going to move on. Health statistics and econometrics. Difficult one to talk about in a short space of time. So instead I've picked some nice funky titles that you might find entertaining. I kind of talked about this earlier on as to how I think about econometrics, so hopefully that's covered this. There is a literature about how to analyse healthcare expenditures or healthcare costs, and for some reason the authors involved decided to go down this Shakespearean front. So you had much ado about two when thinking about two-part models, and to transform or not to transform when talking about whether to transform dependent variables. I think there might have been others that followed this with the Shakespeare theme, but let's not spend too much more time on that because I'm already running over, I think. Just a plug for myself, I've also done some work in this literature, but no interesting titles really, so didn't make the cut. Demand for health and healthcare, so this comes back exactly to your point. Basically, there's this seminal paper by Michael Grossman that's been cited a huge number of times that did this model for how health is demanded using this idea of health capital. And therefore, you can use that model to look at how demand is derived for other things like healthcare, for example. It also has been used to analyse the effect of things like education on health outcomes. Or it's at least a framework for thinking about how that might be affected. At a more sort of policy level, that I think might be quite important, and we've done some work in Malawi along these lines, is thinking about how you might develop a resource allocation formula. So often these are based on demand side considerations, like how much healthcare does a specific area in a country need, or how much would it benefit from, and how could we develop a formula that allocates money in a fair and efficient way across the different areas. And that's you know, building on work that has been done elsewhere as well.
Would you explain the first one more, the health capital?
Whoa. It's a quite complicated microeconomic model, but a big part of it is the idea that individuals have a sort of stock of health, and their consumption behaviours throughout their life will either increase this stock of health or decrease it. And they have some demand for that stock of health, but they also have demand for other things like having money to spend on rent or whatever it might be. So it's a model that kind of analyses that in quite a complicated way with lots of equations. But it's quite an interesting way of thinking about the problem because it helps to organise your thoughts in a logical way and say, well, this could affect this within the model, for example. Sorry, not a very good answer, but it's quite a complicated one to cover in a very short space of time. I'm going to whip through these now. Medical insurance is a big focus. There was this really huge experiment in the US. If you click on this website, there's actually a movie that they made, which is very emotional. It's surprisingly emotional. Someone in this movie is like in tears talking about this project that they did. So it's 15 minutes long, but it's worth a watch if you're interested in medical insurance. There's lots more that's been done in medical insurance. This is just one topic that I found particularly interesting. Supply of health services. So we talked about this a little bit earlier in terms of contracts with Alex saying the work we're doing in Tansi. We actually have a research paper that's now published, and you might hear more about this later on. But health economists are interested in the effect of incentives on behaviours and health outcomes. I'll leave it at that for now because I'm running out of time. I've run out of time. Human resources. There's obviously a huge amount of work to be done on healthcare workforce, for instance, and key topics in the UK are here presented on the left, but on the right, what might be particularly of interest in say, a lower middle income country is thinking about this sort of brain drain effect and the way that the movement of labour across boundaries has potentially led to healthcare workers going abroad. This paper takes quite an interesting view of that and says it's not related to healthcare specifically, although I think they have one example on healthcare. But basically, people go abroad, but they send a lot of money back, so it's kind of ambiguous in terms of the effect on development. Markets in healthcare. If you think about the UK, until relatively recently, I guess, there wasn't really a market per se in healthcare, but obviously in recent years the internal market has been created that kind of fosters this competition between organisational units within the NHS. Outside of the UK, maybe markets in healthcare is an even bigger topic. Thinking about how these markets work in terms of competition, like is there a good healthy level of competition or not, and how does that affect the quantity of services that are provided, but also the quality of services that are provided. I've put on here studies relating to the NHS because I think it's quite interesting how you can think about that even within a single payer system. Another market that obviously is particularly important is the pharmaceutical industry and how is the way that that's organised affecting research and development, because obviously that's a hugely important component of health and healthcare. And then finally, it's the thing that I work on in my team, economic evaluation. And what I wanted to get across here is that economic evaluation is perhaps a little bit broader than it's sometimes described as being. Very often people talk about health technologies. Basically they're referring to new expensive drugs. But it has actually been used more broadly for thinking about healthcare programs more generally, and the Blue Book is the seminal place to go for looking at principles and methods that underlie that. We've also been involved at CHE in working out a Gates Foundation reference case, so that provides some guidance on how economic evaluation should take place. And then even more broadly perhaps, referring back to what Alex was saying, economic evaluation methods and principles have been used in helping to inform benefit package design. But yeah, I'm going to leave it at that now. And then, like I say, what about global health? Well, obviously within those topics I have brought in some global health examples. When you look at the Collier and Wagstaff paper, very few of the very highly cited papers are about global health issues. A lot of them are American issues, to be perfectly honest. But maybe it's time that people thought about global health as being something more important. I mean, what could be more important, really, for health economists? Okay, that's the end of the talk, and I've run over. I'm really sorry.
Thanks very much, James.